Good morning and welcome to the ANA UT Southwestern Patient Education Event. I'm Melissa Bombick with the Acoustic Neuroma Association, and you'll see me moderating question and answer sessions throughout the day. We want to welcome and thank the entire team from the Peter O'Donnell Jr. Brain Institute at UT Southwestern for taking the time and putting a lot of effort into the fantastic presentations you'll see today. Before we get started, I want to direct you to the ANA website and information page for today's event. You can visit anausa.org/UTSW for a full agenda, more information on all of our presenters, and information on technology FAQs. I also want to point you to the toolbar on your screen. There's a Q&A button which will allow you to submit questions throughout the day. If you're on Facebook and you're watching from there, you can just type your questions into the comments. We'll be monitoring those pages as well. And we'll do our best to get to as many questions as we can after the presentations. All of today's presentations will be recorded, and we will have captions added by the end of the week. They will be housed in the video library on the ANA website. We're going to go ahead and jump right in. I'm going to introduce Dr. Walter Kutz, Professor of Otolaryngology and Neurological Surgery at UT Southwestern Medical Center. He's leading our team of presenters today, and will get us started. Dr. Kutz, go ahead.
Thank you so much, Melissa. We're very excited to be part of this this event. We've been planning this for about a year now, and we're very excited when the ANA invited us to co-host this event. Our Acoustic Neuroma team at the University of Texas Southwestern Medical Center is honored to team up with the Acoustic Neuroma Association to bring you this virtual patient event. We wish the meeting could be in person like we initially planned, but since it is 2020 and we're in the midst of a pandemic, we realized the meeting would have to be virtual. The good news of a virtual meeting is the ability to have more participants, and currently we have well over 300 participants registered, and that does not even include our audience that is watching through Facebook Live. So welcome everyone. When developing the program, we wanted to make sure you have the opportunity to learn not only about acoustic neuroma, but also some of the other challenges of being diagnosed with an acoustic neuroma, including hearing loss, facial weakness, balance problems, psychological issues, eye care, headaches, and other issues that come along with the diagnosis and treatment of acoustic neuroma. Our acoustic neuroma treatment team will discuss treatment options, how decisions are made, and go through a few cases to show you how we make recommendations as a group. Our team of audiologists will then discuss hearing options, including hearing rehabilitation, bone-anchored hearing aids, and cochlear implants. Dr. Shai Rosen is an internationally renowned expert at facial reanimation and will discuss his experience with improving facial weakness. Dr. Ron Mancini will then discuss eye problems that may result after treatment for an acoustic neuroma. Doctor of Physical Therapy, Egla Balzate, will discuss treatment and rehabilitation options for patients who develop balance dysfunction. Dr. Josh Bay, who is a neurologist in our group, will then discuss headaches and dizziness and how does it best manage these problems. Dr. Kenneth Dekleva is a psychiatrist in our group that will discuss how patients can cope with the diagnosis of acoustic neuroma and post-treatment mental health issues. And finally, Dr. Laura Klesse and Jacob Hunter will discuss future treatment options. All the speakers today are faculty at the University of Texas Southwestern Medical Center and work together as a cohesive team to manage patients with acoustic neuroma. We believe strongly that patients with acoustic neuroma are best treated with a multidisciplinary team approach and encourage you to find a center with a similar team. For instance, we have a monthly conference where the treatment team meets with each other's as well as with neuroradiology to discuss patients with acoustic neuroma and come up with a consensus treatment recommendation. We'd be more than happy to see anyone in person or as an initial telehealth visit if you do not have access to an acoustic neuroma center close to where you live. Our clinic number is available online and on the ANA website. I would also like to recognize our excellent local ANA chapter co-led by Betsy Poore and Linda Dorsami. Thank you to the UT Southwestern O'Donnell Brain Institute and Teresa Fain, Zoya Khan, Sahizaba, and Lori Enright for their support. Finally, I'd like to thank the leadership of the ANA, including Chad and I, Steffi Romer, and Melissa Bombeck. We appreciate you spending the day with us, and we hope you gain tremendous value for your time. Next, I'd like to introduce Betsy Poore, our local ANA chapter co-leader, who would like to say a few words before we begin the conference. Betsy?
Thank you. Good morning from Dallas. My name is Betsy Poore, and I'm one of the Acoustic Neuroma Association support group leaders for Dallas-Fort Worth. I'd like to welcome you to the ANA Virtual Patient Education event in partnership with the UT Southwestern Acoustic Neuroma team at the Peter O'Donnell Jr. Brain Institute. I was diagnosed with an acoustic neuroma in 2011, treated with surgery, translab approach in 2012, and this event excites me for many reasons. I relied on the Acoustic Neuroma Association to gather information when I was first diagnosed, and it's an excellent source of information. Since my surgery, I've continued to learn more about acoustic neuroma. Some topics were helpful in my recovery and related to specific issues I was challenged with, and at other times there were subjects I didn't know much about, but they were also very eye-opening. Each opportunity to hear from specialists, I'm amazed at how much I still don't know, and I will learn more today. We offer the opportunity through our support group, which is meeting virtually right now, and a handful of the panelists who will be speaking to you today have hosted us at UT Southwestern, where they have presented on a variety of subjects of interest to many patients. We would like to thank UT Southwestern very much for their ongoing support, partnership, and their involvement in the local support group. Your team has not only made a difference in patient care, but you've made it a priority outside of standard office visits into an area I call aftercare, because diagnosis and treatment is only the beginning for so many ANA patients. For patients, educating yourself is key. If I knew then what I know now, I would have had a different experience in places. It's important for you to know what an acoustic neuroma is, but it's also important for you to know what an acoustic neuroma is not. Your providers will guide you with their expertise, but only you can make decisions that are right for your life and your future. The more you know, the better prepared you'll be for anything that comes your way. That knowledge will carry you through your experience. Your acoustic neuroma diagnosis, treatment, watch and wait experience, and recovery takes many different paths, and it varies from patient to patient. It's important for you to know you're not alone, and is another reason why education events like this are so important. In the support group setting, we're able to provide an additional level of emotional support. No matter how compassionate your providers are, or good intentioned your family, spouses, friends, and loved ones are, patients understand what it's like living with and through acoustic neuroma. My personal story is that I had house grade 6 facial paralysis, which is no movement on the affected side, and that impacted me greatly for 3 years. I mention this because it was the most difficult thing I've ever faced, and that was after making all of my decisions and having surgery. I also want to emphasize that in my case, there were no concerns about the nerve. It was intact before, during, and after surgery, but for that to present itself the way that it did, so severe and so late, is uncommon. Not unheard of, but I was that oddball statistic. I felt prepared for everything going into recovery, except for that twist and to that degree. I was unaware there was also a mental aspect to it. For me, I wasn't able to communicate with others due to my lack of facial expression. And it wasn't until I learned how much we rely on that, combined with hearing adjustment, that I knew how to address it properly. Working through any acoustic neuroma difficulties without a full understanding of what is happening, knowing if there may be options available to you or how to begin to adjust, is frustrating and draining. It's education events like this, when you least expect it, that can help point you into the right direction to address your specific concerns, and I'm so grateful that took place for me. Your quality of life at all stages matters. Enlightenment and the opportunity to network with other patients can be a game changer for you. I, like so many acoustic neuroma patients, knows what it feels like to hear the word tumor, only to become numb when the word brain follows it, and not give any weight that benign was also used in the same sentence. In our support group, as with others across the country, we know what it's like to mourn hearing loss, where you feel like something is being taken from you without any say in the matter, where the tumor has already done irreversible damage, or you think you can still hear when the test results clearly show otherwise, or you know there is a chance remaining hearing may go with treatment and you dig in your heels. For patients in those moments, hearing is more important than preservation of life, because that is too far beyond anything we can comprehend. For us, losing the hearing is only associated with losing a big part of ourselves. Other common discussion points is the change in lifestyle. We know what it's like to decline an invitation to a restaurant, event, or special occasion with family and friends because it's no longer enjoyable or pleasant. You can't hear others talking near you or with music in the background, and you stand there while everyone laughs at a punchline and you never heard the joke. You're tired before you left the house. In the support group setting, acoustic neuroma patients are able to interact with others who've had similar experiences. It's welcoming and even a relief. It's not the same as other times in public where you may carry added stress that comes with each contact or apology you make when you ask someone to repeat themselves. If you've beaten yourself down into withdrawal or unintended isolation, the support group is your safe haven. In my experience, it wasn't until I faced the things that were so very difficult and highly uncomfortable that I was able to get to this side from where I'm speaking from today. It was a forced reset in my life. And being here today, you're going in a direction that will benefit you greatly. I understand fear, life-altering change, and what you may be going through now. Our network of ANA volunteers have been there too. You can find a complete listing of the support groups and scheduled meetings on the Acoustic Neuroma Association's website, and we look forward to seeing many of you in Dallas. The medical panel here today, with their expertise and a comprehensive agenda, will touch on many of these items I've mentioned and will help you better navigate this time in your life. I also feel it's important for you to know I'm involved in my life very differently than before my surgery, as are so many other AN patients. I'm doing things I never thought I would do. I'm stronger mentally and physically, and my life is full of the things that matter most. Every day is precious. It took time and an acoustic neuroma. 8 years ago, I wondered what I could ever do to say thank you to two neurosurgeons who by default became two of the most important men I will ever have in my life, as they spent hours upon hours with me in the OR and took great care of me in their precisely skilled hands. I quickly learned early on that one was a neurosurgeon and one was a neurootologist, and that I would need both of them in a team approach for the best possible outcome in my acoustic neuroma treatment. Nothing material would ever be enough to thank them for the gift they have given to me. Diagnosed at 44, it's the next half of my life. One physician has retired, and the other is here today. Both have led, trained, and mentored several of the panelists who will speak to you today. I volunteer for the Acoustic Neuroma Association because I believe patient education is imperative, and it's a way I know I will make a difference. I like to think of it as a way of giving back in ways I wasn't able to be there for myself at times, and a personal thank you for the dedication and expertise these medical professionals give to acoustic neuroma every single day. I'm a UT Southwestern patient, and I'm deeply honored to welcome you to this patient event today. On behalf of the entire Dallas-Fort Worth Acoustic Neuroma Support Group, welcome. It is with great pleasure I present to you the UT Southwestern Acoustic Neuroma team. Thank you.
Thank you so much, Betsy, and sharing your journey with your acoustic neuroma. You know, I think as a surgeon and part of the acoustic neuroma team, we do our best to really to try to understand what patients go through. You know, it's not just a diagnosis, you're treated and it's always done. As you mentioned, a lot of times this affects potentially the rest of your life. So thank you for sharing that. And we've really enjoyed working with the local ANA chapter. You guys do an outstanding job in visiting with the patients. So thank you. So we're going to get started. The first panel is going to be, I have been diagnosed with acoustic neuroma, now what? And this panel is going to be actually individual small presentations about the different treatment options. And we're going to leave some time at the end for some question and answer sessions, but let's have all the question and answer at the end after the presentations. So there's going to be a little bit of a pause where we kind of share our screens. So there'll be a little bit of a transition. So I'd like to first introduce the panelists. Definitely an honor to do this. And I was just thinking today that, you know, if you look at this team that you're seeing right here, this is really about 100 years worth of experience here. When you add all this together, it's pretty incredible when I think about it. And it's very nice when I get to meet with my colleagues and we meet in our conference to be able to discuss treatment options, which isn't always easy. It's not always easy to recommend treatment. There's a lot of different variables that we'll talk about. But when you have a team that really almost has 100 years of experience, it's pretty humbling, and it's just a fantastic place to work and to collaborate. So first, Dr. Sam Barnett is one of our neurosurgeons who specialize in acoustic neuroma. He's going to talk about introduction to treatment options. Dr. Jacob Hunter, who's one of our neurotologists, is going to talk about observation. Dr. Zabi Wardak is a radiation oncologist who treats acoustic neuromas, and he's going to talk about radiosurgery. Dr. Brandon Isaacson is one of our otologists who's going to talk about microsurgery. And finally, Dr. Bruce Mickey is going to talk about his experience gained over 36 years of treating acoustic neuroma. So without further ado, I'd like to have Dr. Barnett start the panel with introduction to treatment options.
Thank you for the introduction, Walt. Good morning to everyone. Just get my screen shared here. Pop up for everybody.
Perfect.
All right, good. Again, good morning. My name is Sam Barnett. I'm one of the neurosurgeons here at UT Southwestern, part of the acoustic neuroma team. And it's most certainly our pleasure to talk to you today. I'm going to talk a little bit about sort of introduce the treatment options for acoustic neuromas before sort of a deeper dive into each option that the other speakers will be presenting. And I was thinking about it, realizing that a lot of this is going to be a little bit redundant for everyone, but it occurred to me that when we see patients in consultation here at UT Southwestern, virtually every patient sees 2 or sometimes even 3 of us to discuss their the treatment strategy for their newly diagnosed acoustic neuroma, and a lot of that is redundant when we they talk to me or they talk to Dr. Kutz, Dr. Hunter, Dr. Isaacson, Dr. Wardak. And so I think that the redundancy actually helps. It kind of like gives people a chance to hear the same thing from slightly different angles, and helps them kind of answer their questions and generate new questions. And they're thinking about what the best thing for them to do is. And so while I apologize if some of this is redundant, I think that it is going to be helpful in the end to hear some of this more than once. So as many of you know, the 3 basic treatment options for acoustic neuroma are observation, radiation treatment, and surgery. So I'm going to talk to you about each one of those just a little bit, and talk to you about how we come to that decision just in a little bit of a way too. So observation, what that usually looks like when we start with that is that we repeat someone's imaging, and that usually means we get another MRI in 6 to 12 months. And as we get more and more information about the tumor, and if we see that the tumor is stable, we can increase that scanning interval over time. We also frequently check the audiograms to make sure that the hearing is stable. And we also monitor your symptoms to make sure that you're not developing any new facial numbness, imbalance, vertigo, dizziness, things like that. And the reason that observation is a reasonable option for these tumors is that they are benign, and that they grow slowly, and that there's no compelling reason right off the bat to jump into treatment most of the time. Certainly, a lot of patients end up having treatment of some form or another, but it's not something you have to jump into. There's usually not a lot of urgency to make that decision. And so with observation, you can get more information about the tumor. You can get to know your treatment team a little bit better and make the right decision for you. Now, of course, every decision we make has its pros and cons, and observation is no different from that. Observing a tumor has very little short-term risk to it. Very few patients develop severe new problems in the interval between their first scan, their second scan, or their third scan. But some of the treatments that we offer that you'll hear about today do have sort of a window of opportunity. For example, hearing preservation surgery. There is sort of a size cutoff, a shape of the tumor, sort of audiogram levels of hearing that we look for to offer patients hearing preservation surgery. And so there is a chance that if you observe your tumor, you may go from a candidate for hearing preservation to a patient that's not a candidate for that anymore. And the same thing is true for stereotactic radiosurgery. There are some size cutoffs that we often use that you'll hear more about, that it is possible that you could be a good candidate for stereotactic radiosurgery, and if you observe it long enough and the tumor grows to a certain extent, you may sort of lose that opportunity. So that is the downside of observation. Option number 2, stereotactic radiosurgery. That is just a very brief description, is a computer-guided treatment where we target the tumor with a very high dose of radiation, and that the normal tissues around it get a very low dose of radiation. And just to be clear, when I say high dose of radiation, I mean high dose for the tumor. And this, the doses of radiation we use for acoustic neuromas are relatively low when compared to cancer, for example. So it's a relatively low dose of radiation, but it's an effective dose of radiation to stop the tumor from growing. And the biggest advantage of the stereotactic radiosurgery is that there is very little downtime, very little discomfort with the treatment. But as always, there are pros and cons to every treatment. The pro, as I just mentioned, is very easy to go through. The downsides of radiation are that there are some delayed side effects. None of the treatments are risk-free, and it doesn't work for everyone. So there are some patients that their treatment might fail, and they may go on to need other treatments down the road, usually surgery. And if that's the case, sometimes surgery is made more difficult by the previous radiation. And then finally, surgery. So surgery is done by a team of surgeons, usually a otologist and a neurosurgeon. Usually involves an incision of behind or above the ear, and you know more about that. Surgery is relatively long, and there are lots of reasons for that. But the main reason is that we spend a lot of time trying to preserve the other important structures in the vicinity of the tumor. The facial nerve is the one that gets all of the attention, and you'll hear more about that later. For most patients, it's about a 4-day hospital stay, and it's about a 6-week recovery process for going back to work or school, for example. And again, the pros and cons of surgery are that the advantages of surgery are that it is definitive treatment. Many patients are cured of their tumor with surgery. We also have tissue of the tumor to send to the pathologist, and we have proof that it is a benign tumor, and also that tissue can be studied for other reasons down the road. Also, surgery has the ability to take pressure off important structures in the area of the tumor, the brainstem, the other nerves that are there. So there are some opportunities to improve other symptoms with surgery that the other treatments don't have. But the risks or the downsides of surgery are relatively obvious, in that there are the risks of surgery, which are being discussed in detail, and then the downtime. And so, as you can see, the 3 options that we offer for acoustic neuromas are very, very different. You know, observation, radiation, surgery are very, very different approaches, very different strategies. And so how do you decide what the right thing for each individual person is? And so there are a lot of factors that go into making that decision. The age and general health of the person, for example, is an important factor. Since this is such a benign disease, slow-growing tumor, we have to think about these treatment decisions in terms of the patient's entire lifetime. So if you have a 30-year-old patient, for example, that is newly diagnosed with a tumor like this, the decisions you make are not for the next year or 2, it is for the next 50 years of their life to decide what the best way to manage this tumor is going to be. So as you can imagine, a 30-year-old patient may be managed very differently than a 70-year-old patient with those things in mind. And the same is true with the general health of the person. So a healthier patient may get slightly more aggressive treatment than a person with multiple medical conditions, for example. The size of the tumor and the characteristics of the tumor are very important. So small tumors are much more frequently observed than very large tumors. Very large tumors, sometimes the only option may be surgery, because it is causing so much pressure on the surrounding structure. The characteristics of the tumor are also important. The degree to which it is filling the internal auditory canal, the amount of irritation of the brainstem, all those things help us decide what the right thing for each individual person is. Hearing status obviously is important. So we handle patients that have good hearing and normal hearing differently than we handle patients that have lost hearing. And then we also have to take into consideration if there's any hearing loss in the non-affected ear. So if your acoustic neuroma is in your only hearing ear, that opens up a whole different set of things to think about when you're planning treatment for someone. The other thing that we take into account is associated symptoms. So hearing loss is not the only thing that patients with acoustic neuromas have. Some patients have vertigo, some patients have imbalance, dizziness, some patients have facial numbness, even facial pain, facial discomfort, occasionally facial weakness, and we have to decide how to incorporate those symptoms into our decision-making process. And then finally, one that is important, but is, I think, sometimes overlooked, but I think is maybe the most important, is the patient's preference. Is that many times there is more than one right answer for the management of these tumors, and the patient's preference is probably the most important thing in the end. And so some patients feel very strongly about one option versus another, and as long as that is a reasonable strategy from our standpoint, we virtually always defer to the patient on the decision-making process. So just a little bit of how we use those factors into making decisions. So you see a patient like this, and so this is an MRI page of a patient. You see the eyeballs up here at the top, the nose is kind of cut off the edge of the screen. Here are the ears here, and here is this tumor. So you look at this tumor and say, what should we do about this particular tumor? And it turns out that just looking at the scan is simply not enough information to make the decision. And so you can imagine putting the same tumor in more than one patient. So if you took this same tumor and put it in a 30-year-old motivated patient with excellent hearing, you may very reasonably decide that that patient would benefit the most after discussing everything from hearing preservation surgery. That may be what this patient chooses to do. If, however, you take the same tumor and put it in a 50-year-old patient with not very good hearing, and you also know that that tumor has been documented to grow on serial imaging, a very reasonable decision for this patient might be stereotactic radiation. And then finally, if you take a 7-year-old patient and this was found by accident because they're being evaluated for memory problems, observation may be a very reasonable course of action. So you can take the same tumor, put it in more than one patient, and you may come up with a very different management strategy. And so you can do the same thing. You can flip it around. You can say, what do you do for a 50-year-old patient with mild hearing loss and a newly diagnosed acoustic neuroma? Well, it turns out that the answer to that question is not straightforward. I mean, there are more factors that have to be considered. So you take that 50-year-old patient and you give them a very small tumor. They may decide that observation is the right choice for them. On the other hand, if you have a more medium-sized tumor, they may think that radiation is the best choice for them, and that would be a very reasonable option. And on the other hand, give them a very large tumor with lots of brainstem compression. Microsurgical resection might be the best choice. So that you have to take into account all the different things: the patient, the factors, patient factors, the tumor factors, and all the other things we mentioned earlier to decide what the right option or right management strategy is for them. So in summary, and I realize we're going to go over all these things again, determining the best treatment strategy for each individual person with acoustic neuroma is a very complex decision. There's not always one right answer. And I think that one recurring theme of today is that most patients are going to be best served by evaluation with an experienced multidisciplinary team to help navigate all of these complex decisions. That is it. Thank you.
Thank you, Dr. Barnett. Excellent overview. I think Dr. Hunter is going to discuss observation as initial treatment for acoustic neuroma.
Yes, thank you. Let me share the screen. Are you all able to see my screen?
Yes, perfect.
Okay, so I'd like to thank the ANA. I'd like to thank Betsy. I'd like to thank Dr. Kutz for putting this all together. Actually, I think, well, this has been in process for longer than a year. I remember this was being set up even before up in Rochester for the quadrennial meeting back in May of last summer. I'd like to thank you guys for participating and logging in. I hopefully this entire day there's going to be something for not only everyone participating, but as well as the panelists as well. So I've been tasked to talk about the role of observation, and I think Dr. Barnett did a great job of highlighting the nuances between tumors based on a number of other variables, emphasizing that ultimately it is kind of patient preference. I mean, I feel part of my role is to provide as much information as possible to help the patients make a decision. So now it's not letting me go through. So I have no relevant disclosures to this talk. I'm going to talk about the option about observation. Obviously, Dr. Barnett did a great introduction. I'm going to talk about inconsistencies about kind of how we measure tumors and why that can complicate things or at least confuse things, I believe. I'm going to talk about a large institutional review that I kind of spearheaded a number of years back, looking at the role of observation, and then talking about a question that was really motivated by trying to improve patient counseling. What can we help patients who do elect to pursue observation? What can I tell them about their hearing down the road to help them make an informed decision when they're diagnosed with a tumor? And then we'll conclude. I think the overarching theme of this, what I want to emphasize is that we are now starting to realize that maybe not all tumors grow after they're initially diagnosed. I think at least the previous generation of surgeons, at least the way I was taught, was that many times patients were diagnosed with these, and these were immediately, hey, listen, these need to be removed. And as Dr. Wardak will speak following me regarding the role of radiation, that has increased, as well as the role of observation. I hopefully can provide a little more information to patients, to you, about the role. So observation. My colleagues and buddies, all of our buddies up at the Mayo Clinic a number of years ago, looked at a large database that was originally designed to track cancer patients throughout the country. Not every single cancer patient, but it's a good technique or a good database to look at cancer trends. And so beginning in 2004, that database started paying attention to vestibular schwannomas, which we by definition would not necessarily state cancer. And so what these guys did is between 2004 and 2011, looked at how many patients pursued observation, how many patients pursued radiation, how many patients pursued surgery. And the point being here is that the role of observation literally increased from 2004 to 2011. And I would argue those numbers are even lower than where we're at today. So again, they looked at over 8,300 patients. And initially at the beginning portion of that review, roughly only 1/4 of patients pursued observation. But by the end, it was about 1/3. If they broke, and not if, but when they broke tumors down to size, and so they looked at only smaller tumors, specifically tumors smaller than 2 centimeters. I think Dr. Isaacson will speak about the size issue and its relation to microsurgery shortly. Smaller tumors were even more likely to be observed than all tumors altogether. So we're looking at the end of 2011, almost half of all patients pursued observation. So what can we help tell patients about that from the get-go? So many studies over the years, I mean, this first paper is from 1995, have looked at the role, or I should say the growth rate of tumors. I mean, if we're going to observe these, we need to understand, are they enlarging? We need to be able to compare MRIs. And while the actual increase, let's say it grows 1 year to the next, doesn't necessarily mean you need surgery. I mean, it provides us a story of what's going on with the tumor. But as you can see, that there's some inconsistency in patient reports, or I should say studies, and there's many reasons for this. Many people measure these differently. It was only until about 2001 that there was an international consensus that you measure it with a line. I mean, these are 3-dimensional objects. These are not flat pancakes that are sitting in the cerebral pontine angle. And so is a line truly representative of the tumor? I do think in the next several years, and we're actually working on this here at UT Southwestern, that all tumors would be able to provide us a volume, or we'd be able to get a volume for all tumors and maybe better characterize the tumor than just a linear measurement. But back in that 2001 Tokyo consensus is what it's referred to. It was defined as a tumor enlargement greater than 2 millimeters was defined as a growing tumor. And there's reasons for that. One, different people who measure a tumor could find different measurements. Two, who's to say one MRI, the head angle is slightly different than the other. I mean, given that these are three-dimensional objects, the analogy I use is, what if you have a pear and you image it slightly differently 2 different years? If you catch the top end of the pear 1 year compared to the bottom end of the pear another year, it's the same pear, but technically that's a larger pear when you look at that one slice in that subsequent image. So these are just single studies, small number of patients. As I mentioned, multiple growth definitions, multiple measurement techniques. But nonetheless, there's been a couple papers that have tried to group all these studies together. And they're looking at, when we define growth as 2 millimeters, again, based on linear dimensions, roughly about 40 to 45% of tumors do demonstrate growth. But I want to emphasize, growth doesn't mean we necessarily do anything. Obviously, if you present or diagnose with a 4, 5, 6, I mean, I'm not going to say a specific number. It grows 2 millimeters, it grows to 6 millimeters. No big deal. I mean, we can continue watching it. So when I was a fellow, I trained at Vanderbilt University, and they've actually tackled an observation approach for quite some time. And so I don't want to discredit or ignore the Denmark team. In the country of Denmark, since 1976, if you were diagnosed with vestibular schwannoma, you go to the exact same center. And they have very interesting data that supports this further. And they just released a new paper. Literally, it's really kind of published ahead of print that includes over 3,700 patients. But that kind of just further reinforces what I'm going to say here. But we looked at 560 patients that had at least 2 studies. And I don't want you to get bogged down in the details here. I hope I'm not confusing patients. But we only wanted to look at tumor growth. And again, defining tumor growth as 2 millimeters. So let's put that in perspective. An average tumor at diagnosis is about 1 centimeter. I just double checked this, but people have studied the size of a green pea quite extensively, and the average length of a green pea is about 1 millimeter. So the average tumor on diagnosis is probably a little larger, maybe about the same size as a green pea, and that's 10 millimeters. 10 millimeters are in 1 centimeter. So we would say if the tumor enlarged between MRI studies 2 millimeters, we would define that as growth. Many of the problems with these original studies is that we have a short follow-up. I mean, this study that we published almost 5 years ago now, we only haven't had an average follow-up of about 2 years. And then we categorized tumors based on size. We grouped small tumors, and then we grouped large tumors, and we looked at tumors overall. And looking at tumors overall, again, our numbers are consistent with what has been published. From a linear diameter perspective, roughly about 40% of tumors grow after diagnosis. So this can be a very complicated slide even for physicians to understand. This is a specific curve. But what I'm trying to emphasize here, and I believe Dr. Kutz is going to maybe share this with you later, is that every single patient that's enrolled in this study starts on the left-hand screen. And if their tumor, regardless of the size, demonstrated growth, or the patient pursued intervention, they fall off. And so you drop down 1 patient. So these are actually every single individual dot of a patient. And so what I'm emphasizing here, there are patients that are reaching the right-hand corner of this screen that demonstrated no growth and decided not to elect treatment upwards of 7 years, 8 years out after diagnosis. That doesn't necessarily mean a growing tumor, again, means intervention. But here are a number of patients that did not demonstrate growth for quite some time. These are all patients. These are patients that are coming in with the smallest tumors to patients that are coming in with the largest tumors. So when we parse it out by size, we notice a difference. So it's a little faint, and I hope it projects, but the red curve on the left is a representation of every tumor over 2 centimeters. And so what that's pointing out is that those tumors are more likely to either grow, or patients are more likely to pursue observation, as compared to the green curve on the far right, or at the top, I should say. Those are tumors less than 5 millimeters. So the point being, and what we'll emphasize, and I'll re-emphasize in a second, is that size appears to matter, which makes sense. A larger tumor at diagnosis portends that it's more likely to grow, which makes sense because it actually got quite large before a patient found out about it. Whereas smaller tumors are much, much less likely to grow. And there's a number of data points we have in there to kind of provide patients an estimation of what that might be. This is also another confusing slide, but I want to highlight a couple things here, and this is reinforced by another paper that just came out of the Mayo Group about why we serial image these patients, why we just don't get one image. So the top row here is categorizing patients based on size. So the left column here is all patients that had a small tumor, and the right column is all patients that had a very large tumor, over 2 centimeters. I don't want to say it's very large, but larger than 2. What we're pointing out here, what I'm trying to emphasize here, in the lower left, there were 9 patients that had tumors less than 5 millimeters that had follow-up of at least 10 years. And of those 9 patients, 1 patient demonstrated growth. Nonetheless, so again, I want to emphasize long-term follow-up is warranted. Nonetheless, there is 1 patient, and I'm wondering if my screen is blocking it. There was 1 patient who actually elected to observe their tumor that was larger than 2 centimeters. And after 8 years, it still did not demonstrate growth. Now, arguably that beat the statistics, but it still, again, reinforces 1, long-term surveillance matters. 2, big tumors don't necessarily still grow. And I think I'm losing it from my pictures. And this was recently reemphasized from the Mayo Group when they looked at long-term surveillance is needed, that there are patients that roughly about 5% of patients can first demonstrate growth after diagnosis upwards of 10 years out. So we generally recommend an MRI roughly every 6 to 12 months, usually in the first 5 years annually, so every year. If it doesn't grow after 5 years, we generally recommend an MRI every other year. And then if we're getting to 10 years, we're recommending an MRI every 5 years. I'll admit, given the new onset or the new practice of observation, there are not that many patients yet out to 10 years, but a gentleman I just saw yesterday, I mean, we're looking at starting to stage his MRIs just because we've watched it long enough, it's demonstrated no evidence of growth. Lastly here, I want to emphasize the rate of intervention and highlight the top of the screen here. But those tumors that were under 5 millimeters, only 5% of patients ended up electing to pursue treatment. Whereas on the far right, tumors that were greater than 2 centimeters ended up, or 80% ended up pursuing some form of treatment. So we looked at a number of factors: age, gender, hearing were not predictive of growth. There is some associations that patients who present with some form of dizziness, whether that's defined as dizziness, vertigo, disequilibrium, imbalance, there's an argument that that might be an indicator that the tumor is more likely to grow, and that has been reinforced with some other studies. And then ultimately, as I said, larger tumors are more likely to grow than smaller tumors, but that doesn't necessarily mean a patient needs to pursue intervention. So real quick, lastly, what's the role, or I should say, what's the influence of hearing if you observe the tumor? And going back to that example Dr. Barnett proposed, let's say you do have a small tumor, you are diagnosed with an acoustic, but your hearing's normal. We can offer a hearing preservation surgical approach. But this is motivated about what is the risk of hearing loss if you continue to watch the continue to watch the tumor. That had actually never been clearly published before. So this is a paper that I did with the Mayo Group. We kind of combined patients. We kind of were working on it separately, and we realized, wait a minute, we're doing the same thing. Let's combine them. And we really looked at a very basic metric, whether a patient would wear a hearing aid. And it's not that simple, but that's probably the best example. If a patient would still like to wear a hearing aid, because some patients, if the hearing gets significantly worse, a hearing aid won't be of any assistance. So we were looking at those patients who elected to pursue observation, how many of those patients ended up wearing a hearing aid or would be able to wear a hearing aid at the end of the study. And so again, similar curve to what I presented earlier, those are all patients on the left who were able to wear a hearing aid and diagnosed with a tumor at the time of diagnosis. And roughly about 10 years out, the data and statistics get weak when we get to the right. Roughly 50% of patients still were able to wear a hearing aid despite watching their tumor. What we also did with this, and this is a complicated slide, but nonetheless, this is actually kind of an actuarial table, and I don't know if I can actually use the term actuarial here, but what if I could give you a percentage? So we actually looked at patients who, we looked at the data that those patients who presented their ability to understand words and then their ability to understand tones. So for example, for someone that had good, excellent word recognition with normal hearing at diagnosis, so I'm highlighting that 90% word rec and 20% pure tone, they have an 84% chance, give or take 80 to 90%, that they'll still be able to wear a hearing aid in 5 years. And the point being here is generally patients who present with good hearing at diagnosis, If they present with normal hearing compared to the other ear, chances are you're going to preserve that. But the data suggests, and you can see in the lower right, if you have hearing loss, chances are no matter what you do, you're probably in the end eventually going to lose your hearing. When that will be, we obviously cannot predict that. We've actually done some other studies with this about the change in hearing loss, how that might play a role in predicting. But the hope here is to provide patients better information when you're diagnosed with a tumor, what to expect in regards to the hearing if you did elect to observe it. So in conclusion, as I pointed out at the beginning, I want to emphasize, we understand that not all tumors grow after diagnosis. Nonetheless, however, delayed growth can occur. And so we do encourage those patients who pursue observation to maintain surveillance. Nonetheless, obviously, if there's no evidence of growth, we can start spreading that out. Larger tumors at diagnosis have a greater risk of further growth. And then if there is hearing loss, there's the general counsel that accelerated hearing loss is likely to occur in that year. So again, I'd like to thank Dr. Kutz, Betsy, the ANA for putting this together and the invitation to speak on this. And I'll turn it back over to Dr. Kutz, and I think we'll leave the questions, as Dr. Kutz mentioned, to the end. So thank you.
Yeah, thank you very much, Dr. Hunter. Great overview of observation, which is, as you mentioned, is our most frequent recommendation initially for most tumors, not all tumors. There are questions coming in. We're trying to answer those as we go, but we'll also leave some time at the end for questions. Our next speaker is going to be Dr. Zabi Wardak, who's a radiation oncologist who treats just about all of our acoustic with radiosurgery, if that is indicated. So Dr. Wardak, when you're ready.
All right. Good morning. Can you see that all right?
This looks great. Thank you.
All right, perfect. All right, yeah, and thank you to the Acoustic Neuroma Association for inviting me to speak. It's an honor to be here with all of you patients diagnosed with acoustic neuromas. So I'm going to talk about radiosurgery. So what is radiosurgery? And this is a little Saturday morning humor for us. So it's a technical term, and there are a lot of semantics when it comes to radiation oncology. And this is not what it is. What it actually is an umbrella term, and as Dr. Barnett had introduced, an umbrella term for a highly potent focused dose of radiation delivered with high accuracy to the tumor. Now, the analogy I always like to give my patients is that if the tumor were a glass window, if you were going to break the glass window with one large rock, then that would be the equivalent of radiosurgery, versus traditional radiation would be the equivalent of throwing many pebbles at that window until ultimately it cracks. Now, under the umbrella of radiosurgery, there are many different ways in which it can actually be performed. So depending on the facility in which you guys visit, there are many different ways it can be done, including what you may hear as LINAC or linear accelerator radiosurgery, cyberknife radiosurgery, as well as gamma knife radiosurgery. And all of these are different technologies that I'm going to introduce that treat acoustic neuromas in subtle, slight, but important different ways. Now, if I were to first introduce LINAC radiosurgery, these are common machines that you may hear known as a TrueBeam or a Versa. And what these are linear accelerators that deliver focused radiation with a patient laying down here on the couch and the machine which rotates around. Now, behind all of this fancy plastic, what's actually happening here on the left, this shows the development of the X-ray or the radiation. And as you can see, as it's developed, it's ultimately created into many different shapes. And this is actually an image here on the right that shows the leaves within the head of the machine that are shaping that radiation ultimately to the size and shape of the tumor itself. Now, with linear accelerator or LINAC radiosurgery, what's commonly done is that a patient would undergo a simulation process in which they would have a mask fitted, which you can see here on the left. And then ultimately, when they come in for the treatment, they would be laying down flat on the couch, just like so. And at the machine console, before the treatment is actually delivered, what the machine has the capability of is obtaining an image, which you can see here in the top left, of the patient exactly before the treatment is delivered. And then below here in the bottom left, this is a reference. So we call this a checkerboard image. And what this does is it allows us to precisely line up the patient's position just before the treatment. And what you can see here on the right, an also important portion of any form of radiosurgery, is monitoring of the patient during the delivery of this highly potent, highly focused dose of radiation. And here you have cameras in the ceiling, which are monitoring with X-rays during the treatment delivery process to make sure that the patient is not moving and it maintains its accuracy. So that's LINAC radiosurgery. So what is CyberKnife radiosurgery? So behind the scenes, it's still X-ray radiation, but the way in which it's delivered is different than a LINAC. So this is a picture here on the left of our CyberKnife. And the machine itself, it's not restricted only to going in one beam angle. It's built here on this robotic arm, commonly like those robots that build cars. And what it does is it allows the radiation to be delivered from multiple different trajectories. So this is advantageous in that as the beams are coming in from all of these pinpoint trajectories, any single beam is delivering very little radiation, so its entrance and its path to the tumor is minimal. And at its convergence point, that's where it builds up and it's focused and it conforms right onto the tumor itself. So like LINAC radiosurgery, the patient would be on the couch with a mask. The CyberKnife also has X-ray imaging that during the treatment, the X-ray images are being obtained, and you can see this here in the center image. And the CyberKnife is very unique and very nice in that what it does is during the process, while it's obtaining the images, it's adjusting the couch for sub-millimeter motion of the patient. So as you can imagine, trying to be perfectly still with that mask on, it's not possible. So the machine itself, what it's doing, it's taking that into account and it's adjusting for it. Now, lastly, I'll introduce Gamma Knife radiosurgery. So this is a picture here of the latest model of the Gamma Knife, known as the Gamma Knife Icon, here in our facility. And what's unique about the Gamma Knife is that there are 192 pinpoint sources of radiation that come from all angles, and they all focus and converge right on the tumor itself. So again, this is much like the CyberKnife in that you have 192 beams, they're all pinpoint. So on their way in, as it's passing through all of the normal brain and healthy brain tissue, it's not going to hurt that healthy brain tissue, and it's all going to focus in and converge right on the tumor itself. Now, Gamma Knife radiosurgery has historically been only able to be delivered with a stereotactic head frame, which you can see here on the left. This is commonly what you would hear and associate with Gamma Knife radiosurgery. You would have this frame placed with these 2 pins here in the forehead and then 2 here in the back. And the technology has fortunately evolved, whereas now we have the option with the Gamma Knife to be able to treat patients either with the frame or with a mask now. And the mask, which you can see here, is fitted. There's a marker here which we place here on the patient's nose. And here you can see some more images of the patient in the treatment position. And there's a camera here at the foot of the bed, which is monitoring the patient during the entire process with this graph, which you can see here. And it's ensuring that the patient is still and not moving during the treatment. Now, with that introduction with the different technologies, how is it actually utilized and what are the differences in the techniques between the different modalities? So here's an image here of a patient treated with Gamma Knife radiosurgery. So here on the left and the right, this is the same exact patient with 2 different plans. Now on first view, if you look at it, they don't really look too different. However, based on the experience and the technique of the physicians who are delivering the radiosurgery, if I zoom in here, what you can see here, the yellow line is the prescription or the focus of the highest dose of the radiation that we want to deliver. What you can see here in the green line, these are lower doses of radiation. This orange contour that you can see here, this is the cochlea. So if you compare one plan versus the other, while initially they may have looked the same, if not very similar, as you look at subtleties and nuances, here we've done specific shielding to really be able to shape that radiation away from the cochlea and hopefully try to improve the chances of hearing preservation. So this is just another image of that same exact patient with the two different plans. Again, here on the left, what I would do is I would zoom in and I would show you here in the orange with the cochlea. You can see that overlap of those lower doses of the radiation with one plan. And then here with the different in technique and the planning process, how you can steer and shape that radiation away. So this is always important to ensure that your providers have this experience and understanding of the nuances of the technology and the treatment planning process. Now, what if we were to compare the Gamma knife versus the CyberKnife versus LINAC radiosurgery? So this is still that same exact patient with the same tumor, with a plan developed with each of the different treatment modalities. Now on first glance, when we look at it, you can see here that yellow or prescription looks nice and conformal, here in the orange with the CyberKnife conformal, and then here in the red with the LINAC, nice and conformal. What you can also see here is that this was our best plan with the shaping of those lower doses. The CyberKnife does a very nice job of it as well. And the LINAC is able to do it, but you can see here there were some compromises in that because of the nuances in the technology, it's compromised some of the coverage of the tumor. And that's problematic in that you're actually under-treating the tumor and potentially compromising your control. But if we get further granular, you know, these are technical plan comparisons that the physicians would be looking at. And if we look at the maximum dose of radiation delivered to the cochlea here on the left, and then here, this is the gradient. This is a measure of the fall off or the lower doses of radiation as they spill away from the acoustic neuroma itself. And as we did these comparison plans, you can see lower numbers are better. So you want to have a lower dose to the cochlea. You also want to have a steeper gradient or lower doses of radiation going to healthy normal tissue. And as you can see, the Gamma knife here and the second iteration where we had that shaping and the blocking, this kept the cochlea to the lowest dose. So hopefully that gives us the best opportunity to maximize the opportunity for hearing preservation, as well as it gives us an excellent gradient or fall off in the radiation itself. Second place you can see here would be the CyberKnife, and that also did a good job, but you could still see there are subtle nuances here that when you compare one to the other, the Gamma knife does appear to be superior. So in conclusion, what I would say is that not all radiosurgery is the same. You know, we're fortunate here at UT Southwestern in that we have all of these treatment modalities and we have experience utilizing each. So we like to hope that we're being very objective in how we're choosing which treatment machine for each patient. And we've decided that the Gamma knife is the best for our patients. And it's also nice to understand that, you know, not all experience is the same. You know, if you treat 1,000 acoustic neuromas with only one machine and you don't have an understanding of the different technologies that are available, you may not know that there may be a better option for other patients. So really, you know, I'd urge all patients to just make sure that they discuss with their providers, their technology and their techniques. And we're always here and available if you guys have any questions in the future. Thank you.
Thank you, Dr. Wardak. That was an excellent overview of radiosurgery, and appreciate you explaining the differences in the modalities of treatment, radiosurgery. We're very fortunate. We have an excellent radiation oncology department and really all the different modalities. And like you said, the Gamma knife seems to be the best for our group and our patients. The next talk is going to be by Dr. Brandon Isaacson. Dr. Isaacson is going to discuss microsurgery as a management option for acoustic neuroma.
Good morning, everybody. Thank you again for allowing us to host the 2020 ANA meeting. We are we are again thrilled to be part of this event. And again, we're sorry it can't be in person. Hopefully next time. So I was charged with talking about the different surgical approaches for acoustic neuroma, and I'm just going to get started. And so historically, we've categorized these into hearing preservation and non-hearing preservation approaches. You'll notice that you typically have heard of the three different approaches, which are the retrosigmoid, translabyrinthine, and middle fossa approaches. Those are the ones that you've historically heard of. I'm going to also go into a little bit of detail about the transpromontorial approach, which is a newer approach that's was promulgated by an Italian surgeons, and I'll go into a little bit more detail about that. Historically, the original approach for acoustic neuroma was the retrosigmoid approach, which was initially kind of used by Harvey Cushing way back in the era, I think in the 1920s and 30s, before we had nerve monitoring and microscopes and all the advanced technology that we now have at our fingertips at the time of surgery. Bill House was the initial proponent of the translabyrinthine approach. And again, I'll go through some illustrations of these different approaches to kind of, so you have some idea of what they entail. And that was where honestly, where the field of neurotology or otology was born, was with Bill House and his introduction of these new techniques to the skull base, and particularly the translabyrinthine approach. He also reintroduced the middle fossa approach for acoustic neuroma surgery as well. It was initially used to treat patients with otosclerosis that involved the inner ear, but he found it to be a viable option in patients who had intact hearing with small tumors. And again, I've already briefly discussed the transprom approach, and I'll go in more detail about that. So incisions. So, patients typically want to know, what kind of incisions are they going to have after each of these approaches? So these are the two hearing preservation approaches I mentioned before. There's the middle fossa and retrosigmoid approach. These images come from the Stanford Otology Atlas by Dr. Jackler and Christine Grolop. I want to make sure I give them credit for these. But with the middle fossa approach, there are essentially three different options. You can, the approach that was described in this atlas was kind of a U-shaped flap. So you'd make an incision starting here and all the way around here, and all this tissue gets reflected down towards the ear, including the muscle underneath the scalp called the temporalis muscle. Another approach is just making a straight line incision in the scalp. Obviously, this is a hair-bearing area, so some people will preserve it. If you do this U-shaped flap, they'll preserve a large tuft of hair right here and shave a line around the incision. I know Dr. Barnett's kind of more of a minimal hair shaver on some of his approaches when we work together. For our center, we typically use this question mark incision for middle fossa approaches, and you can also sometimes use a linear incision as well. The advantage of linear incision, it's the easiest to close and the quickest to close. And obviously, it's a little less soft tissue disruption. Underneath, once you've elevated the skin flap, there's also a muscle underneath here called the temporalis muscle, which is one of your chewing muscles that we have to move out the way in order to expose the skull. And we remove typically a 4 by 4 centimeter, 4 to 4.5 by 4 to 4.5 centimeter piece of bone that exposes the temporal lobe dura. And ultimately, that's what we retract in order to expose the top of the internal canal in order to remove the tumor. The retrosigmoid approach, again, which is the oldest approach, involves an incision further behind the ear, at least 2 finger breadths behind the ear. This little piece of bone right here is called the mastoid process. And that incision is going right behind there into the muscles. And then we reflect this anteriorly and posterior with the retractor, and the bone that we're removing is essentially right around here. You probably heard, there's some approaches where you don't remove as much bone, called a keyhole approach. That's another option for the retrosigmoid approach. And again, we typically in our center use the retrosigmoid approach for hearing preservation cases with tumors that are in what's called the cerebelloponsin angle. There are some centers that use the retrosigmoid approach for every tumor. And we actually utilize all 4 approaches depending on the patient's tumor, their hearing status, and obviously patient selection. But these are, again, the typical incisions that you would see with these two approaches. The other two approaches are the transapophyne approach. This is another illustration. This is actually from the Cohen-Goodall's neurosurgery atlas, and it involves making an incision behind the ear a little bit larger than the retrosigmoid approach. Some people have described an incision that just goes behind the ear, and that exposes the bone right behind the ear called the mastoid bone. And that's the approach, that's the bone, the temporal bone is the avenue which the transapophyne approach utilizes to get to the tumor. We always think of, larger incisions and maybe more pain and discomfort. And at least in our experience, most patients, honestly, regardless of the incision you use, they do have some pain and discomfort, but it doesn't seem to be a big rate limiting step, whichever approach that you use. And then lastly, the transprom approach. This is a minimally invasive approach that actually goes through the external auditory canal. And this is showing a patient after they've healed, but essentially the incision involves removing all the ear canal skin, and then we take the skin on the back surface of the structure called the tragus and close it to this skin in here, which is called the concha. But we use this, and we use the ear canal essentially as our approach into what's called the internal auditory canal. And so this is, again, that new minimally invasive approach where you can remove a small tumor through the ear canal. And again, this is a non-hearing both of these are non-hearing preservation. This one, you're going through the balance system called the vestibular system, the semicircular canals and vestibule. And this approach, you're going actually through the cochlea. And so with anytime you interrupt the inner ear or the bony labyrinth, which contains your hearing and balance mechanism, you're not going to be able to save hearing. And so, these approaches are typically only offered to patients who already have poor hearing. So just to go in a little bit more detail about the anatomy of these approaches, this is again from the Jackler-Christine Grollup surgical atlas. What it shows is they've done a U-shaped flap. They reflected the muscle and the skin inferiorly over the ear. And this is actually the surgical position you would be in. So the surgeon would be sitting right here, and you would have your surgical technician here, assistants here, and we would be looking at this through the microscope. And what this is showing is that this right here is the temporal lobe, which is part of your brain, and it's got a covering called dura, which covers it. And what we're doing is basically exposing this bone, and then eventually we're going to open the internal auditory canal from above, and we're going to remove the tumor from around the facial nerve and try to preserve the cochlear nerve, as well as obviously the facial nerve, and try to preserve hearing. So this is the cochlea right here. This is the facial nerve. Actually, this is wrong. Actually, that's the superior canal. My apologies. This is cochlea. This is facial nerve, and we're trying to preserve both the facial nerve and the cochlear nerve, which are here, and the balance nerves are right here. The retrosigmoid approach, again, is that incision further behind the ear. This is the classic approach to the internal cerebellar-ponce angle tumors, and the advantage of it is it's a relatively quick exposure. It does not take that long to get a good exposure for this, but you can see they have a retractor blade in here to move the cerebellum out of the way. So one of the disadvantages of this approach is that you retract the cerebellum, but if you do this approach correctly and position the patient correctly, it's rare that you actually need to use a retractor to do this. And the reason for that is the brain actually, once you drain the spinal fluid off, the cerebellum actually relaxes out of the way, and it's not usually a problem. So you can use this approach for any size tumor. I think the main advantage of it is if you have a tumor in this space that's relatively small with good hearing, then you can access that tumor quite quickly and try to preserve hearing. There are some centers that will try to remove tumors in the internal auditory canal through the retrosigmoid approach. We do that on occasion, but in general, if the tumor is in the internal auditory canal right here, and it's not in the angle or minimally in the angle, then our center prefers the middle fossa approach for hearing preservation. If there's more tumor in the CP angle here, then we would typically, and they have good hearing, then we would typically use the retrosigmoid approach. And again, if it's a bigger tumor, anything over 15 to 20 millimeters, probably more 15 millimeters, your chances of hearing preservation are not going to be that great, and we're going to prioritize facial nerve preservation over anything else. And then this is the translab approach. So instead, again, they have a retractor in here. Again, I don't know the only approach that I use a retractor on is the middle fossa approach, and you need to retract the temporal lobe dura out of the way. And actually, once you drain spinal fluid out, you don't even need the retractor. But one of the advantages of the translab is you don't have to retract the cerebellum at all. It's really not the way because you're going straight through the temporal bone. What this is showing is that we've inner ear has been, the balance portion of the inner ear has been drilled away here. And again, you can see the actual tumor right here and the internal auditory canal. In our hands, this is our workhorse approach at UT Southwestern. If someone has a tumor with poor hearing and any size tumor, this is our preferred approach. And again, that's center and surgeon dependent. Not every center, every center has different nuances on how they like to manage these tumors surgically. The transplant approach, I didn't have as great of an illustration. This is from Dr. Marchione, who's one of the Italian surgeons, along with Livio Presutti, who described this approach. This is an approach where we actually go through the ear canal. You can see here's the ear canal. This is the mastoid bone, which is the typical way we go through a translab approach. In the transprom approach, we go through the ear canal. We have to remove the hearing bones, and we go straight through the cochlea to get to the internal auditory canal. So this is a CAT scan in a coronal plane showing the side of your head. This is the external ear. This is more towards your neck. And white on here is bone, black is air, and gray is soft tissue. So we are going to go through the ear canal here, open up the cochlea and vestibule, which is right here, and then you're going to be looking straight at the internal auditory canal. So if you have a smaller tumor in this canal with poor or no hearing, this is an approach that now is available that you can use to remove these tumors. One of the potential downsides now is, and we'll get to hearing rehab discussions later in the morning, is that there are now opportunities where we can sometimes remove a tumor and try to save the hearing nerve, even if we don't save hearing, and put a cochlear implant in at the same time. And with the transplant approach, that's really not possible. So because you're going through the cochlea, you really are destroying any type of framework you would need to put a cochlear implant in. And that's really the only option that would allow you to restore sound perception to that ear. So that is a big downside to the transplant approach for a small tumor, is that there really is no option for restoring hearing in that ear. And again, doing cochlear implants in acoustic neuroma patients is a relatively newer thing. We do that more for neurofibromatosis 2 patients because they have bilateral tumors, but for unilateral tumors we have historically not really considered that, but we are now doing some of that, or offering that. Facial nerve outcomes, really between the different approaches, there are really not a lot of long-term differences between the outcomes for facial nerve function. I would say that if you compare, we did a paper a long time ago when I was a resident looking at small tumors, comparing the middle fossa to the translab approach on facial nerve outcomes. Initial outcomes with the middle fossa, because the facial nerve is right in front of you in a middle fossa approach, the early outcomes are probably a little bit less favorable with the middle fossa, but long-term outcomes were equivalent for similar sized tumors. And as far as all the approaches together, really long-term differences have not been demonstrated with facial nerve outcomes with the approach. It's probably more a factor of what your surgical team is most comfortable with for these approaches. And again, hearing outcomes, it really just depends on the size of the tumor, how much residual hearing is left. And again, our only 2 surgical approaches for preserving hearing are going to be the retrosigmoid and the middle fossa approach. In our hands, the middle fossa approach tends to be a better option for hearing preservation, but we've also had some success with the retrosigmoid approach. So that is my presentation, and I will turn it back to Dr. Kutz.
Thank you, Dr. Isaacson. Excellent overview of the microsurgical approaches. So for the final portion of this panel, we're going to have Dr. Bruce Mickey kind of talk about his experience with acoustic neuroma. And I was going to ask Dr. Mickey a couple questions. Dr. Mickey, can you hear me okay?
I can hear you. Can you hear me?
I can. Thank you very much. So how many acoustic neuromas do you think you've treated over your career? Maybe we could start with surgically.
Oh, somewhere between 500 and 1,000, I think.
Okay.
The numbers were in the 600s years ago when I last counted them, and it just didn't seem worthwhile to count them beyond that.
Sure. Okay. And how many tumors do you think you've treated with radiosurgery?
Maybe 50. I don't have as good a feel for that number.
Yeah, sure. So what do you think's changed the most in the management of acoustic neuroma over your career?
One change has been the ability to monitor the facial nerve intraoperatively. When I started, we did that with a little stimulator, and the anesthesiologist crawled into the drapes with a flashlight. And as you know, we now have a very sophisticated way to monitor the facial nerve during surgery and to predict when it has tolerated as much manipulation as it can tolerate, and we know when to stop. And sometimes that is before the tumor's been completely removed. The change that goes along with that, of course, is the availability of radiosurgery to manage small tumor fragments that cannot safely be removed. And I think between those two advances, we are better able to save good facial function in large tumors than we were 30 years ago.
Mm-hmm. Yeah, it's you know, in my career, we always had the facial monitor we have now, and you know, oftentimes I imagine how difficult tumor dissection would be without a facial monitor. You know, all the tumor and the nerves. You know, with experience, you're able to see some of those fine subtleties to differentiate a facial nerve from a vestibular nerve, from a cochlear nerve, from the tumor. But especially on larger tumors, they'd be extremely difficult. So it's pretty amazing that even more in any kind of facial monitoring that surgeons can remove tumors and preserve facial nerve function. What do you think about the role of observation? Have you seen more tumors being observed over your career?
Well, I think that with the evolution of MR imaging, acoustic neuromas are now discovered at a smaller size than they were 30 years ago. And many of them, as you know, were discovered before they produced symptoms, others only mild hearing loss. And as Dr. Hunter pointed out, and Dr. Barnett, when the tumor is small, because we can observe the growth rate so carefully with MR imaging, observation is a reasonable management option. That wasn't the case 30 years ago.
Okay. Yeah, that makes sense. And you know, it's pretty amazing what you can see, the detail of MRI technology has come so far. You know, one thing that, you know, oftentimes if we're just observing a tumor, the subsequent MRIs, we may elect not to use the contrast because MRI technology is so good. We know a tumor's there, and so we can follow tumors without contrast. And that's, you know, I think it's convenient for patients. It's less expensive. You don't have to have an IV. You don't collect contrast. So that's one change I've seen over the past 13, 14 years since I've been here. So how do you, you know, when you first started here, you know, it's probably you and Dr. Meyerhoff, Dr. Rowland, and how do you have you seen the multidisciplinary approach kind of expand over your career? It seems like now we have this really large team in place with, you know, plastic surgeon, neurology, physical therapy, audiology. Have you seen that multidisciplinary expansion improve patient outcomes?
There's no question that it has, and the addition of Dr. Wardak and his colleagues in the Department of Radiation Oncology to give us the option of leaving a small tumor fragment behind rather than putting the facial nerve at greater risk than is fair has been one part of that. And then certainly, no matter how good you are and how lucky you are, as Betsy pointed out at the start, there will be some patients who have a weak face afterward, and having facial reanimation capability provided by Dr. Shai Rosen and his colleagues has been a tremendous addition. And then lastly, I'd like to acknowledge the work of the Acoustic Neuroma Association. When I started, if we finished the operation and the facial nerve worked well, we thought we'd done our job and that was it. And I didn't really appreciate the need to grieve for hearing loss in patients who had some serviceable hearing. We told them up front we weren't going to save it. We didn't. And I wasn't a very good listener then. I think that even for the patients who have a good facial nerve outcome, hearing loss is a real loss. And Betsy pointed that out in her introduction. And for patients who do well, there's a post-traumatic stress disorder sort of syndrome that's worse if you have a weak face. And I think Betsy alluded to that in her introduction. And that is something that the vestibular rehab people and all of us have begun to pay attention to. But it's something that the Acoustic Neuroma Association really helps with. And the ability to talk with other patients, other people, other families who've been through a similar experience makes it far easier to get from where Betsy was at the start of her journey to where she is now. And it was really gratifying to hear her describe that process. That's part of the hope for the future, I think.
Yeah, I agree that, you know, like you say, as a surgeons, we do remove a tumor and hope the facial nerve functions great, and we feel we've done a great job. But as a patient, you know, you're dealing with things the rest of your life. So Dr. Mickey, how do you initially approach a patient and a family with a newly diagnosed acoustic neuroma? What do you kind of tell them? And are there things you say to sort of put things in perspective? If you're diagnosed with a brain tumor, I mean, my immediate response would be, am I going to die from this thing? And how do you initially approach the patient and family with a newly diagnosed acoustic neuroma?
Well, I think Dr. Barnett really outlined that well, and the fact that not all acoustic neuromas are the same, and the answer for a 30-year-old is different than the answer for a 70-year-old, and I'm almost 70 now, so I'm not picking on old people. And the answer for a 4-centimeter tumor is different than the answer for a 1-centimeter tumor. I think they're at the edges of that spectrum. The 30-year-old person with a 4-centimeter tumor and a numb face and impending hydrocephalus, there's really only one option. And that person has to be told that although this is a benign tumor, it absolutely needs to come out and it needs to be removed as completely as possible. And that should be done at a center with an experienced surgical team and an experienced support team. On the other hand, for a 1-centimeter tumor and a 50-year-old person with okay but not great hearing, as Sam pointed out, I believe our job is to explain these options well enough to help the patient make the right decision for him or her. And that is a difficult process, and that benefits from repetition. I believe that it's beneficial to have a discussion with Dr. Wardak or one of his colleagues, and have a discussion with one of the otologists, have a discussion with Dr. Barnett, and then go home and let the right answer come to you. I don't know any other way to say it, but I'm always wary when a patient comes in and says, well, I saw Dr. Jones or Dr. Smith, and he or she told me there's only one way to manage this tumor. That's true for the minority of acoustic neuromas. For most of them, there are options, and depending on where the patient is in life, what his or her occupation is, family situation, the right answer for one person is not going to be the same as the right answer for another.
Yeah, great points there, Dr. Mickey. Does any other panelists have any questions or comments for Dr. Mickey or overall?
Yes, I can ask Dr. Mickey a question about your experience with radiation over the years, and how have you noticed and seen things change and evolved with improvements in technology, and your thoughts towards radiation?
Well, having shared some of that story with you, I agree with you that delivering the radiation in one dose is more effective than delivering it in multiple doses. Can't always do that, but when you can, delivering it in one dose is superior. And the gamma knife, in my opinion, does provide the most accurate dose delivery and the greatest ability to minimize radiation to surrounding normal tissues. That's a small advantage, I believe, and I I don't want to give the impression that acoustic neuromas cannot be treated with some of the other technologies that you described. But if you ask me my preference, it is the Gamma knife, having had experience with the CyberKnife and having had experience with delivering the radiation in multiple small fractions. You're throwing pebbles at the window analogy.
Any other questions for Dr. Mickey?
No hard questions, please.
Yeah, oh no. Dr. Rosen, welcome. I think you're maybe muted. Check your mute function. Or are you just waving?
Yes, correct. Yes, thank you. So Dr. Mickey, where is the future taking us in terms of treatment of acoustic neuromas?
One of the things that we haven't spoken about in detail is the problem of neurofibromatosis type 2, which is a small subsegment of the acoustic neuroma population, but one for which we don't really have an effective answer at the present time. And it is my great hope that we will one day have an effective medical therapy for that disease, and that may provide an effective medical therapy for acoustic neuromas. And as much as Dr. Kutz and Dr. Barnett like to be in the operating room, I think they would agree with me that they're very willing to support research to find non-surgical options. But that's in the future. At the present time, I think the panelists this morning have given a very accurate overview of what we have, and all of us do our best to make your job not necessary. But I can tell you, speaking on behalf of everyone, that it is gratifying to have you as a backup for those patients for whom we can't preserve really good facial nerve function. And I will thank you on behalf of everyone else on the team. And he didn't even say that. I want to point that out.
Thank you.
I have one question for the team. I've seen another center present that they are looking into future having an injectable dye during the surgery to actually illuminate the facial nerve, and actually you can see it. Are there any advancements being done across the board for that?
Does
I think
anybody want
Dr. Barnett would be a good person to answer that question.
to? Dr. Barnett, you just got the difficult question. Hope you're still muted. I'm sorry.
I lost in the shuffle there. So I think that I think that the nerve physiology we use is probably the best way to find the facial nerve, and because not only do you have real-time information about its function, but you can track its pathway. And so I'm not familiar with the research about lighting up the nerve with dye, but we are looking at some new imaging modalities where you can potentially predict the path of the facial nerve before surgery, whether it is in the sort of the usual position or in a more varied position, which would be helpful information if you could figure that out before the surgery. So that's obviously not the same thing that you're talking about, but I'm personally more excited about knowing where the facial nerve is before surgery than finding it during surgery, because I already think we have a good way of doing that.
I believe there's actually a clinical trial to speak to what Dr. Barnett's speaking to regarding the diffusion tract imaging. I forget the center, but I'm almost 100% positive there is a clinical trial out there to explore that very question Dr. Barnett's interested in.
And I'd also like to say that that there is an element of salesmanship in some of the techniques and technologies that are presented at national meetings and to patient support groups, and you have to be wary of that a bit. And I think that we on the panel this morning have made a real effort to speak the truth and to talk about our own personal experience and and to present all of the different options, but to discuss what we do and what works for us. I think the situation may be a little similar, to speak to Dr. Hunter's former career as a baseball player, to asking a pitcher what pitch he should throw with the bases loaded and a full count. And one guy's going to say, I go to my fastball, and another one's going to say, I'll throw a curveball every time. And I think you have to let the team that you've chosen use the technology that has worked best in their hands. And it's important that you find an experienced team, and then you're going to have to trust them a little bit. And I'm always wary when someone says, oh, I have a way that's better than everyone else's way. It's not that simple.
Good point, Dr. Mickey. I think we're at the end of our time. I want to give everybody a short break. Melissa, did you want to say a couple words?
Yep. Thank you guys all so much. These were really fantastic presentations. We're, again, so grateful to all of you for taking the time and giving us this information. So we are going to meet right back here. The webinar will continue. We'll have some videos and presentations going on, but we're just going to break for about 10 minutes. I'll ask all the presenters to turn their cameras and their microphones off, and we'll go ahead and meet back here at 9:40, and we'll start with our next panel, which will be about decision making. So we'll be right back. Thanks so much.